right. So hello, everyone. Good morning, afternoon, or evening. Thank you so much for joining us in another NoBeC Talk. My name is Paulius. I am the Managing Director of the Center for Social Norms and Behavioral Dynamics at the University of Pennsylvania. And today we will follow a very similar agenda to our previous talks. There will be a very short welcome by myself. Then we will have the pre-recorded video of an early career researcher that is presenting today. Today it would be Dr. Amanda Gapster. And then we will have the main talk by Ben Cislaghi and Gary Darmstadt. And at the end, 15 minutes for questions. Just a reminder, as always, that this speaker series is organized by our Penn Center for Social Norms and Behavioral Dynamics. We are a research center at the University of Pennsylvania that works with all kinds of organizations around the world to enact positive behavioral change. We do mainly consulting, research, and training. You can see here our webpage and the QR code to our Twitter account if you want to keep up to date. And as always, also, I want to share a little bit of some of the work we are currently doing or have done in the past. In this case, I want to direct your attention to this report that we did as a result of Penn UNICEF WASH social norms workshops. Also based on the work and the books of our founding director, Christina Vicari, and it's called Applying Social Norms Theory in Community-Led Total Sanitation Programming. You can find the report in our website in the link that you see at the bottom. And just for you to have an idea of the content, you will find there very clear explanations of the theory of social norms, which we work on, how to measure social norms, norm creation, and the limits of the social norm approach. So yeah, I hope you enjoyed that report. A few ground rules. If you have never joined us before, please mute yourself. Please try to keep your camera on if you can to have a more interactive experience. If you want also, please change your name to reflect your affiliation, to know where you're joining from. For questions, you can use the chat anytime during the talk, or at the end, you can use the raise hand function as well. We are transmitting live on Facebook, and as always, the recorded video of this talk will be uploaded to our webpage next week. All right, having said this, we will go with our early career researcher for this week. Dr. Amanda Gapster is a researcher from the Gorgas Memorial Institute for Health Studies in Panama. The presentation is called Gender Norms Among Adolescents in Two Communities of the Comarca Gabe-Buglé in Panama. And in this link and using this QR code, you can access the full paper. So I am going to play the video. All right.
Amanda Gapster, and I recently finished my PhD from London School of Hygiene and Tropical Medicine, where Ben Cislaghi was one of my supervisors. I work at the Instituto Conmemorativo Gorgas in Panama, and I'm going to be presenting part of my research work for my thesis. So I'll be presenting on gender norms among adolescents in two communities in Panama. So first, to start out with, what are gender norms? Well, gender norms are based in theories of social norms and gender norms. They're actually social norms that define acceptable, appropriate actions for women and men in a given group or society. They are embedded in the formal and informal institutions, nested in the mind, and produced and reproduced through social interactions. They play a role in shaping women's and men's often unequal access to resources, freedoms, and thus affecting their voice, power, and sense of self. And this was defined by Cislaghi in a paper in 2019. So with sexual behavior, gender norms can affect sexual behavior in a number of ways. One of those ways is defining or what is appropriate as the appropriate age of sexual debut, condom use, and the meaning people give sexual activity, reproduction, and abstinence as well. With hegemonic norms, there's much research that has been done, but it's mostly been done in high-income situations or countries. And these are, with sexual activity, these are defined as men being sexually assertive and women practicing sexual passiveness. What about non-hegemonic norms? Well, there's been some work done around the world. And for example, Devries and Free in 2010 worked with North American First Nation populations. And they found that the young adults in this population presented both as hegemonic and not so hegemonic norms. For example, males or men tended to practice sexual aggressiveness and females sexual passivity. But at the same time, young women were active participants in sexual negotiations, such as condom use, and young men may be the object of coerced sex, and they weren't always interested in sex. So to give you a little bit of background about the Comarca NoBeC, it's an indigenous region in Western Panama. If we look here, there's Costa Rica and Colombia down here, and Panama is right in the middle. And so in Western Panama, there's this region of about 7,000 kilometers squared and over 200,000 people who live here. So there's very few hospitals and pharmacies within the Comarca NoBeC. And there are some health centers. There's 14 health centers scattered throughout. However, it's not quite enough for everybody. So the HIV prevalence in the Comarca is double that, the rest in Panama. And in a cross-sectional study we undertook also during my PhD, we found among adolescents 14 to 19 years old, high prevalence of STIs, especially active syphilis, HIV, chlamydia, and high-risk genotypes of HPV. So we're quite aware that indigenous populations may construct gender norms differently than what has been described in high-income countries. But many times when we undertake sexuality education, we look for interventions that can be used across the country. However, as in Panama, as in other places around the world, there's probably this one-size-fits-all approach does not work. So we wanted to look at in the study how gender norms influence how young people in the Comarca NoBeC engage in or not engage in sexual intercourse. In order to do this, we undertook a qualitative study. I used participant observation for 1 month, and then I moved to the last part of the month, semi-structured interviews. So we used, within the interviews, we used vignettes, and we used these characters. This is Juanita and Mario, who acted out, this is Juanita and this one's Mario, who acted out a number of different situations. And the adolescents and I could interact, and we could do the interviews that way. So we looked at women's voice and the decision to engage in sexual intercourse, and we played this on a spectrum from absent voice to total voice. A couple of examples from absent voice. A young man, Tachi, said, "The man decides, because the woman never says anything. Women don't talk about these things." Betchy, a young woman, said, "Well, if a boy wants to have sex with a girl, he will just tell her to have sex with him. Girls around here, well, we're shy. We don't talk about these things. If boys bring it up, girls say, no, I don't want to talk about it. The girl will just do it." Mego gave us an example of negotiated voice. She said, "I was in primary school and he was in high school. I was going to walk home and he was there. He told me he would walk me home. I told him no, but he came with me. I told him no again, but then he would always walk me home. Then one day he told me to have sex with him. I said no, my mom would get angry, but eventually I let him. Then he got me pregnant." In a couple examples of total voice, Unchi, a young man, said, "The man has to accept whatever the woman says." And Hoti says, "We cannot force a woman because she knows what's best for her. The man proposes and the woman provides." Melikan and Komenchi similarly stated that this total voice is really dependent on the woman's life stage. For example, before a young woman or a woman becomes pregnant, she can decide if she wants to have sex with a man or not. But after she has a baby, this moves more into absent voice, and she cannot say no. In conclusion, young women seem to have a spectrum of voice and therefore agency in the decision to occasional sex. And there doesn't seem to be strict hegemonic masculinity and passive femininity in sexual decision-making in the comarca Nove Buglé, at least among young people. Thank you. I look forward to hearing from you.
Thank you so much, Amanda, for your presentation. Let me go back to my presentation. Yeah, so thank you so much, Amanda. Amanda is here with us in the audience, so if anyone wants to ask her any questions or connect or comments or whatever, please write in the chat. And once again, you can access the paper here with this QR code. So yeah, thank you so much. And then let's go to today's main talk. So our talk today is called Gender Norms and Health, Insights from Global Survey Data. The speakers are Dr. Ben Cislaghi from the London School of Hygiene and Tropical Medicine and Professor Gary Darmstadt from Stanford University. So I'm going to present each of the speakers and then I will give you the floor. So Ben Cislaghi is an assistant professor of social norms at the London School of Hygiene and Tropical Medicine at the Center for Gender, Health and Violence. There he coordinates a learning initiative on social norms and gender-based violence. In the past, he worked for various NGOs and international organizations, including UNICEF, the World Health Organization, the International Labour Organization, and was a researcher at Stanford and Columbia universities. And he was also the director of research, monitoring and evaluation of the NGO TOSTAN. He is interested in how community-based responses can achieve change in social norms and reduction in gender-based violence, and in the role of social norms, among other factors, in influencing people's actions. And Professor Gary Darmstadt is an associate dean for maternal and child health and professor of neonatal and developmental medicine in the Department of Pediatrics at the Stanford University School of Medicine. He was also in the past a senior fellow in the Global Development Program at the Bill and Melinda Gates Foundation, and also a director of family health there. He has also been an associate professor and founding director of the International Center for Advancing Neonatal Health in the Department of International Health at the Johns Hopkins Bloomberg School of Public Health. So thank you so much for accepting our invitation. And I'm going to stop my screen share so that you can begin.
Thank you, Paulus. And then if I know the right prayers to the gods of technology, we'll be able to share. Oh, perfect. Just a small correction. I'm an associate professor. Not that it matters, but it kind of matters. So to my ego at this time.
I'm so sorry, yes.
No, that's fine. Probably I sent you an old. It's completely my fault. Yes, so thank you, everyone. The order of the names should actually be the other way around, because Gary was really the brain and heart of the initiative that he will start by presenting. But Gary and I specifically worked on the results that we are going to present as part of this presentation. I brought particular expertise on the norms piece and the gender norms piece. And we both hope that this will be a very interactive and interesting presentation. We are aware that the audience comes from different paths of life and disciplines. Both Gary and I work in public health institutions, which of course explains why throughout the presentation you will see that there is a strong interest and focus on how gender norms affect health and health-related issues. So without any further ado, Gary, I would invite you to kick us off, if that's okay.
Ben, thank you very much. Paulius, thank you very much. It's really wonderful to be here with you all. I have to thank Ben for his invitation to me to join him. We've been working together very closely since the Lancet series was first launched, and I'll have to gently correct Ben that I think he's the brains behind the gender norms constructs here, but we're really pleased to be here together, and we'll be going back and forth and presenting this information. You can go on to So what we're going to be talking with you about today is coming out of the Lancet series work that's shown here. There were 5 papers in that series that were published in May of 2019. I hope you all have had a chance to read those papers. There are a number of different aspects that the papers cover. I'll briefly mention that in my next slide. We really were aiming to get beneath issues of gender equality and to look at the normative influences around those aspects of inequality with the notion that there are some common principles, common values that are driving many of those inequalities, and that rather than look at one inequality at a time, let's try to look at the common factors driving them, sustaining them, creating them. And specifically in our case, we were interested in looking at the connections with health. But as you'll see as we go through the presentation, it's around health and development broadly. Interestingly, this was funded by the Bill and Melinda Gates Foundation alongside the United Arab Emirates government. We're seeing movement in places around the world that have interest in gender equality and in normative influences. So I think this was an encouraging sign. We're going to be focusing today more on what came out of the Lancet series, but as you can see, there are many supplemental papers which have since followed. Within our own research groups, some of the thinking and processes that we're going to take you through today have really stimulated a lot of ongoing collaborations and additional work that's captured in these supplemental papers. If you look under Ben's name or my name on PubMed, you can find most of those. And I think a couple of the things that I think we're most proud of coming out of this whole series is the global network that came together around these ideas. That there's a massive amount of interest in scholarship in these issues and in translating these concepts into actions on the ground that really make a difference in people's lives. And so we continue to work with many of these collaborators that we brought together, and that this was a highly multidisciplinary collaborative effort. We're going to be focusing today on some of the approaches that we developed and took to try to quantify ways using global survey data that gender norms impact health. So go on to the next slide. So here's an outline of that series. We were really aiming to further develop rigorous evidence for the impact of inequalities and restrictive norms on health, recognizing that there have been decades of outstanding scholarship in this area, including at your institution. We were really looking to identify opportunities within health systems, within policies, programs, research around data, to call greater attention to the importance of gender norms, ways in which those norms can be transformed, and how those lead to improvements in health. And one of the best things about it, I think, is illustrated here today. We're having a new conversation, meeting each other and talking about common interests, and that was one of the main goals of the series. As you can see here, the first paper really laid out a framework. We laid out a conceptual framework for how gender inequalities are generated and how those lead to disparities in health as opposed to differences in health due to sex. We're going to focus today on the second paper, where we're looking at global survey data. The third paper in that series looked at what happens when you try to transform norms through programs, and what are some of the principles that emerge from an analysis of those studies and the factors that are necessary to come together to produce change. The fourth paper is one that you might be interested in, where we took a more systemic view, looking at health systems and looking at ways in which health systems are biased, discriminatory, and that really reflect the inequalities of the society in which they're embedded. And that in order to change health systems, we really need to take a broad look at societies and look at ways of disrupting the current status quo within those systems. And then paper 5 brought it all together in a call to action. Okay, next. Okay, Ben, over to you.
Thank you. So as part of the work that we did on gender equality and gender norms specifically in the series, we also had to start by defining and clarifying the difference between sex and gender. Some of you might be surprised to realize that actually very often gender in the medical literature specifically is often used as a more polite word to say sex. So of course we started by the understanding that sex is biological determined, which in itself is a contested standpoint, and yet is largely agreed in the mainstream feminist sociology. So that sex is chromosomes, reproductive organs, genitalia, hormones, and that the system that is based on this differentiation between sexes is socially constructed, and that's what is called gender, which includes roles and responsibilities, the fact that women are caretakers and men breadwinners, the attributes, the entitlements. For instance, the fact that that in certain contexts, men will go out and work outside of the household and women won't, and attributes and so on and so forth. Now, gender is a system. Gender in itself is a system that includes several constructs, including gender identity, which is one sense of self as being a man, a woman, another gender. Gender stereotypes and beliefs and construct, roles and responsibilities, and of course expectations, norms, which are really, in a simple definitions, are those unspoken rules and mostly unwritten rules about which behaviors are acceptable for people who are recognized and associated with a certain gender. This slide specifically says male, female, but of course this expands to people of all gender. So that these expectations and rules affect people's actions, because they allow certain people to carry out certain actions and not other people to carry out those actions, and can of course affect health. One very simple example is a rule, an unwritten rule or an expectations or a gender norm by which women are not supposed or expected to go to the hospital alone. And this is very often the case for those of you who study sexual and reproductive health. Now, gender norms are existed across for as long as society and language probably and rationality existed. They are found everywhere in time, space, and affect people of all genders. So very often we believe that because gender equality and the material differences that we witness are so much disadvantageous to women, we tend to forget that gender norms can actually be very harmful towards men. So in the pictures on the left and on the right, in the extreme left and right, we put two examples of expectations, in this case related to fashion or clothing, appropriate clothing for two different points in time, high heels and corset, and how they can obviously affect women's health, high heels by inflaming the joints and corsets by displacing organs. And at the center, there is a picture from a study done by Harvard professor and published on the Business Hardware Review on men's gender norms on oil rig platforms, where the study found that because men did not feel appropriate to show their fears and insecurities, the amount of accidents and death was much higher than normal, and what could be prevented. Now, gender norms also intersect with a variety of other factors, which obviously increases the complexity of identifying in existing global data sets and isolating their specific role in affecting people's health-related choices and actions. Gender norms can and do intersect with institutional factors such as laws and government structures, with individual factors such as level of education, aspirations, skills, self-efficacy. They intersect with social factors such as the availability of models, the existing of a social network and support, the family structure, polygamous versus monogamous, and obviously with material factors, availability of services, transport, infrastructures. So in other ways, another way of saying this is that the intersectional system that surrounds the people's experiences is strongly affected by gender, but of course has to take into account other levels and other categories of social discrimination that go beyond gender. Now, as we did this work, it was very interesting because we were trying to get in conversation aspects of social norms theory that come from philosophy, social psychology, and where social norms are very well defined as expectations, and we have very measurable nowadays theories that kind of define and structure what social norms are. And yet we try to put that stream of thought in conversation with the feminist sociology that define gender norms in various ways, yet in ways that were compatible with our work. And they understood gender norms as part of a larger gender system that prescribed what gender-related expressions and behaviors were acceptable, and that specified how gender norms act upon individuals in shaping their standing and options in the world, as well as their position on the social ladder, which then influence access to resources and freedoms. So this kind of trying to put in conversation these two streams of thought and literature led to a conceptual framework, which is very well defined and explained in paper 1. I won't go into detail, but really what the conceptual framework was pointing at is how from being born as people of a specific sex, male, female, or intersex, then being grinded by the cogs of the social production of gender at home, in the community, within the school, the workplace, and then how this then creates a social positioning of gender, which is obviously intersectional, because it intersects with race, class, age, and ability, which eventually in turn results in different gendered pathways to health, which includes, and these are also explained in the series, which includes difference in exposure to risk factors, different health behaviors, drinking for men or smoking in certain places more than women, access of healthcare, biased health system, and biased health research, which eventually leads to health inequalities and outcomes. So then we kind of started to look at the ways in which in the existing data, we can start identifying, if not yet in this first step, the influence of gender norms specifically, more so the influence of gender as a first step. And these are, this is data from the Global Burden of Disease data. Specifically, these are data on the disability adjusted life years of the causes of DALYs. And you will see in this slide specifically, you see causes of DALYs that affect disproportionately women over men. Now, some of these are clearly biological, right? Or at least have a large biological influence. Breast cancer affects 93 times women more than men in terms of DALYs. And it's easy to understand that this is probably largely driven by sex, by the biology of women's bodies. Now, trachoma, on the other hand, is one of my favorite cases, more than eating disorders, because a trachoma, for those of you who don't know, is an infection of the eye. And when it's repeated, it can lead to blindness. Now, there's nothing in the female eye that makes it more exposed or vulnerable to trachoma. But because children are the main vector for trachoma, and women are socially considered the caretakers of children, then women are much more exposed to trachoma than men. And the same is true for men. Here's another example: road injuries. There is nothing biological. Well, actually, this is a mixed. The evidence is mixed because hormones might drive men's recklessness. But of course, there is also an added component of there being an expectations that real men defy risk and danger and drive aggressively, so that road injuries are much higher for men than for women. Or to put it more precisely, road injury affects 3.69 times men in terms of causes of DALYs. And others are also interesting. We're not going to go into this, but this is also published as a separate paper on the Journal of Global Health. So what we know that it's not just about biology, it's not just about women. And then we brought into this initial analysis an intersectional analysis, so that we see, for instance, that when we take the case of road injuries, a man aged 20 to 24 will be much more likely to lose DALYs because of road injuries compared to a man 45 to 49. At the same time, a man in a low income country, which will be much more likely of the same than a man in a high income country. And finally, a man living in Latin America and the Caribbean will be much more likely than a man living in North America. Of course, there are institutional, there are material factors driving these differences that intersect with those gender norms. So this was really our starting point. And then we faced a challenge. So Gary, back to you.
Great, thank you, Ben. So as Ben has introduced, I mean, a lot of the concepts around gender norms have come out of deep scholarship and much of it using qualitative data. Our challenge here was, could we go to global survey data and could we develop quantitative methods to try to gain some ability to quantify the impact of norms on health and development? That was really fundamentally our challenge, and to integrate social norm, gender norm theory and build off of that theory in creating our quantitative constructs. Next slide. So yeah, I think you can go right on, Ben. So this is a map of the data that we ended up using, and I'll preface this by saying we started out with what I call a boil the ocean phase, where we pulled in data sets from around the world. We identified 17 different multi-country data sets that collected information about health and development in some way. And we began our quest by thinking that perhaps we could identify common measures, common indicators, could potentially harmonize those indicators across different data sets, and would be able to expand our ability to identify factors that influence norms in health across the whole spectrum of sectors within global health and development. We ended up finding that maybe could be done, but it would take years. And so we began to take a very different approach. And this here illustrates the specific data sets which we gained access to through specific partnerships. And we began to focus in, so you go to the next slide, Ben, in a particular way as illustrated here. And it took us a while to come around to this approach. As Ben just illustrated with the global burden of disease data and looking at DALYs, we had to begin where we had some sex differential in an outcome. And we had to begin where we had a sense that there was a normative component, there was a social component in generating that differential between, say, males and females. And just to say, our data here is really, we're all talking about male and female, because when you look at global survey data, that really is all that we have. It's a huge gap in our data in truly looking from a gender perspective at the diversity of genders, but in this case, we're really constrained to looking at male and females, but know that we recognize that difference. So first of all, we had to identify an outcome that had some social dimension to it. We had to think about a norms proxy. In rare cases, we had data that you might call a reflection of norm more directly. But in many cases, we had to infer, based on what we were seeing, where a normative influence might exist. We then sought to identify a reference group, some group that may be enforcing the norm, and figure out a way to juxtapose the group that we're studying to the reference group as a way of understanding the way in which that norm may be affecting the group of interest. And then we had to figure out the statistical methods to enable us to answer a specific hypothesis that we were testing. So this was the roadmap that we developed. As you see at the top, we had 18 different case studies. I think we've developed a few more since. We would invite you to apply this methodology. We're in the process of finishing up a paper in which we describe this methodology in more detail, in hopes that many people will come into this and attempt this. I think it's a really exciting and fruitful area of investigation. We sought to identify case studies that illustrated the role of norms across the world, across the age spectrum, and across just about any health outcome that you could think of. One of our analyses was around the impact of programs that have been implemented, and we found in that analysis that the work has really focused almost entirely around sexual reproductive health, violence against women, HIV to some extent, and rarely did it venture to outcomes beyond that. In studying gender norms, part of the message that we were conveying through this series is that norms affect all of us in profound ways. They act upon us all through our life cycle, all across the world. And so we sought to reflect that in the case studies that we brought forward. Okay, next slide. Okay, and then the next one. So our first case was around HIV and recognizing that the HIV prevalence among adolescents in Africa is about threefold higher in girls than in boys, and asking the question, why would that be? There might be some biological reasons. In fact, there are. But we sought to understand, are there normative influences that we could describe quantitatively? We identified a module within the DHS. We used some machine learning techniques to scan data and try to get a sense of what was within the data. We came upon this module that was unique to the 2007-2008 period. And to us, this illustrated, this is exactly what we're looking for in terms of quantitative data that would enable us to begin to gain some gender-related insights into what may be leading to, in this case, higher HIV prevalence in adolescent girls. This question asked, should young women wait for sex until marriage? It asked the question of men and women about women. It asked the question of men and women about men. And so it gave us a rich constellation of variables to work with. And we then constructed a variable to look at, did they actually do that? Did people actually wait until they were married to have sex? And rather than going by something that people said, which would be subject to a number of biases, we tried to estimate what that might be based on what people said independently about age at first sex and age at first union, and could infer who had sex before they were married. So this is the construct that we started with. Next slide. We first looked at the attitudinal data about men and women should wait for sex. Here we're looking at what men said about men and what women said about women, but when you did the other crossover, it largely looked the same. And looking across countries here, you can see that by and large, people are saying, yes, men and women should wait. There is some hint here that there's a double standard where more often people are saying that women should wait and maybe men don't have to wait quite so much. There was not a terrible amount of variability in this data when we're trying to relate variables to one another. Having variation in those variables really helps. And so we went on to look at the behavioral data that we had calculated in the next slide. And here you're starting to see much more variation by country and by sex. And that sense of a double standard is emerging even more strongly. So now when you go on to the next slide, where we brought these together, looking at, does the attitude reflect the norm? Does the behavior reflect the norm? They probably both do in some ways. But we became very intrigued by this data from Zambia. We also had excellent data on HIV prevalence from Zambia. In much of our work, we were trying to look at clusters of behavior. We had data at the provincial level. And now here we had this highly variable and what we began to call discordant information between what people said you should do, their attitude, and what people actually did as best we could calculate. And we felt that this discordance was really quite an interesting concept. And if you go to the next slide, we captured it in this cartoon. And this is how we envisioned it that kind of led to our hypothesis. And here you have on the left, the adults in the community saying, well, the youth should not have sex before marriage. That is our attitude pretty much across the board. And some of the adults are saying, well, but we did have sex before marriage, but they're going, no, we don't talk about that. And the adolescent is saying, I don't talk about sex. It's not safe to talk about it. And as a result, I don't really know about safe practices. I don't go and seek condoms, for example. And now when she's in a relationship, the couple is saying, this is not something that we talk about. And our hypothesis is, as a result, then adolescent girls become at higher risk for HIV infection than boys. That was our hypothesis. Our quantitative data can't entirely answer the reason why that might be, but we pose the question, might that be? And so here's our data now. So this is broken out by province across Zambia, looking at the HIV prevalence at the provincial level, and on the y-axis, on the x-axis, we're looking at the discordance, the difference between at that provincial level what adults in the community said their attitude was about you should wait compared to whether they did wait. And you can see that the higher that discordance, the higher that the differential between what they said and then did, the higher the prevalence of HIV within those Zambian communities. This held up for women, for adolescent girls, but it did not hold for boys. And so our hypothesis actually was borne out, that there's something going on here that is particular for girls. And we began to call this the taboo gap. If you go on to the next slide. So in essence, we found that for every 10% increase in this level of discordance, this taboo gap, was associated with, nearly a 30% increase in HIV risk for adolescent women that we could not explain by behavior alone. And so we find that in regions where it's particularly strong in that community, that the adolescents are observing, they're seeing, well, this is not something that we talk about, but yet I see people doing it. I don't really feel that I can go and seek any kind of information or any kind of services, but yet I'm going to have sex, and that places, in particular, adolescent girls at high risk. We've gone on to do now qualitative research, looking at the literature to see whether this idea is borne out, and it turns out that it's really strongly borne out in the qualitative literature. This is a paper that we're just going to be submitting next week, but what we've come down to the idea that there are normative influences at home, in schools, in churches, through the community, through cultural events that place girls in more of a subordinate position to the boys. The girls are often having sex with older men, often for economic reasons or reasons of choice. And there's a whole variety of reasons that end up placing them at higher risk than adolescent boys, but it's fundamentally generated by this taboo gap that is insulating them from the health system and from seeking services. So here's an illustration of where the quantitative information did support our hypothesis. And then it really led us into asking the questions, why might this be, which got us into the qualitative research. Let's go on to the next case. We're going to give you a variety of cases. How are we doing on the time? Are we doing okay?
Yeah, we are doing fine. But we have, Gary, we have one short clarifying question about non-voluntary initiation by Jacqueline. Jacqueline, do you want to make the question?
Yeah, no, I'm at USAID and support DREAMS, which is PEPFAR's program in Zambia to address exactly that vulnerability for HIV among adolescent and young women. I don't have the data for Zambia, but often that first, there have been studies about your first sex act is actually not voluntary. It's not coerced. So it is coerced. So I'm wondering if you get to that later on. Over.
Right. We didn't have data to look at that specifically. I mean, we do have some data that we've looked at with regard to multiple sexual partners on the part of men versus women. And interestingly, in the DHS, men admit to having multiple partners. Women pretty much say that it doesn't happen. And so, I think our quantitative data is fairly limited in trying to get, to this particular issue that you're raising, and really trying to understand what might be beneath this. Part of what, in relevance to DREAMS and in this paper that is going to be coming out, we talk quite a bit about ways in which development programs themselves have helped to generate the taboo gap, and now some of the programmatic ways in which we're trying to overcome some of those principles that were put into place, some of those normative factors that are in place. We hope that the value of this research is in calling out that, this may be a very important factor going on, that if you're, introducing a family planning program, for example, and you're not aware that these normative issues, this taboo gap is strongly at play, supplies alone obviously are not going to do it. You're pointing out another, social construct that's extremely important to consider, and there we really need to go to the local level and get local information to understand that at a deeper level. Okay, so I'll go through this one quickly, and then Ben, turn it back to you. Go on to the next slide. This one we call mental health. It really has an intersection with nutrition, and it's fairly common across the world, particularly as societies become more westernized. That there's a normative influence around girls being thin and boys looking strong or even bulky. And here you see this reflected in our cartoon, that this message is coming from various places in society. It can lead to body dissatisfaction, and our hypothesis was that this leads to a variety of health outcomes, including eating disorders and poor mental health. So in this case, the first case was Zambia and DHS data. This is a case of a longitudinal data set. Go on, Ben, to the next slide, where we had a variety of pieces of information that we pulled together and created a construct that we then tested quantitatively. We had information when adolescents were age 11. What did your parents think about your weight? Did they think that you were appropriate? Did they think you were thin, fat? Then there was some questioning around age 15 about, are you satisfied with your body in relation to your peers? And then there were measures of mental health at age 18. Go to the next slide. So this was the data that we had, and we go ahead and go on to the next slide. We analyzed the data in such a way that we disaggregated it by the parent's perception, by male, female, by our main outcome was the SRQ score, or the higher that score, the more mental health challenge there is, the more depression there is, for example. And here, as you can see in the data, we took all normal BMI kids. So these are not kids that actually have a weight problem, according to global standards. And here you can see that if you're a girl, and if you thought at age 11 that your parents thought that you were fat, you developed body dissatisfaction, and that was associated with a higher SRQ score or mental health, poor mental health at age 18. So this is a way of quantitatively unpacking the idea that as an adolescent, your environment really matters to you. Your parents' view matters to you. Your peers matter to you. What you see in the media matters to you. And that comes together to create this situation where your perception of what your parents thought when you were 11, we are hypothesizing, is now a factor in your body dissatisfaction and now in your mental health at age 18. And so this is another example of where we develop quantitative models to test out these kinds of relationships and pose what really are our hypotheses now about what may be going on, so that we can begin to unpack some of these factors and think about how do we mitigate these factors? How do we prevent them from developing? And just raising awareness in this case around an adolescent issue that has to do with mental health. So Ben, I think I'm back to you.
Thank you. We're going to give another couple of case studies. And by the way, just to add to what Gary just said, Gary, maybe we could also say that together with the Brazil study, there was also a study in South Africa where we found a very similar pattern of influence among peers. So we really hope that you can read that in the paper, because it was a very nice example with very clear data on norms. We also looked at employment norms and how could they affect violence or increase violence, experience of violence for young women. Particularly, we looked at whether women who contravened gender norms related specifically to the expectation that women should not work outside of the household. So women who contravene that norm, we looked at whether they experience higher violence from their partner, their husbands, most likely, compared to women who instead did not contravene that norm, respected the gender norm. And we did that by using data from the VAX, the Violence Against Children survey in Nigeria, data collected in 2011. And we found confirmation of our hypothesis. So you see in the graph two communities, so-called restrictive communities and non-restrictive communities. In this case, the sample was young adult and adolescent female living in Nigeria. And by restrictive communities, we mean those PSUs or those small sample units in which most women did not work outside of the household. By non-restrictive community instead, we intend communities where most women did work outside of the household. So in a way, we used the behavior as an aggregate, as the most likely proxy for what was considered acceptable in the community in lack of better data that we would obviously have welcomed. So then, once we categorized these two communities, we looked at what happens to a woman who works or doesn't work in communities where most women work and most women don't work outside of the household. And we found that in those communities where most women were working outside of the household, the home was not the norm, or where the norm was you're not expected to work outside of the household, we found that in those communities, women who did work outside of the household, so we could say in our hypothesis who contravened the norm, experienced higher rates of intimate partner violence and sexual violence, and also physical violence, by the way. The same wasn't true in communities where women were common for women to work outside of the household. Now, another example, a final case study, which comes from a high-income country, particularly the United States, wanted to look a little bit more at how gender expression intersected with gender norms. Particularly, we looked at the extent to which acting non-normative behaviors could affect a variety of health-related issues, including self-related health, weight control behavior, depression, delinquent behavior. So to do so, we used data from the adolescent study conducted in the US, which is a large sample, over 20,000 participants, adolescent age 11 to 18, data collected in the school year 1994 and 1995. So the way these data were exploited, were used, was by, number one, so this data set includes a variety of action and attitudes that people are presented with, and they are asked, the participants are presented with, and participants are asked whether they perform those actions and whether they agree with those attitudes. So people might be asked, do you play football? Do you enjoy shopping? Do you put makeup on? Do you like poetry? And then people are also asked, how do you identify, what is your gender identity? And people could say, well, identify as a girl, identify as a boy, etc., etc. Then we created a measure of what was considered for each school, what behavior were most common in people who identified as girls and in people who in participants who identified as girls and in participants who identified as boys. Say, for instance, allow me for a simple stereotypizing. Imagine, for instance, that in a given school, boys typically liked football and girls didn't. Then we looked at those girls who did like football. So those girls who, despite identifying as, or those people who identified as girls, but kind of contravened the norm by expressing their being a girl, doing things that in that school were more typically associated with being a boy, such as I said, playing football or similar things. And similarly, we looked at boys or participants who said they identified as boys, but enacted actions, expressed their being boys with actions that were more typically in the school commonly exhibited among girls. And we found that more masculine girls were likely as compared to girls in the middle of the spectrum, more masculine girls were at greater risk for a variety of health related issues. We mentioned here weight loss, delinquent behavior, depressive symptoms. Similarly interesting, boys who were on the very high spectrum on the masculine side also had expressed some health-related, were more likely to have unhealthy expressions, unhealthy outcomes such as delinquent behavior and weight gain specifically. Similarly, girls and boys who were more on this side of the spectrum exhibited patterns that put their health at risk. So essentially what we found was that adolescents who were highly masculine and feminine were at greater risk of a variety of adverse health outcomes and behavior compared to peers in the same school and the same sex who were at the median of gender expression. And really our key point here was that being outside of the, in this case, outside of the expectation of a given gender meant being at risk of bullying or ostracization, isolation, that in turn resulted in the desire to either come back with unhealthy control of their body, or that resulted in the antisocial or depressive symptoms. So all these case studies led to some key messages and recommendations.
Yeah, and Ben, maybe just to add, quickly there on that study, we also looked at social mobility, and very interestingly, it was the highly masculine boys who were relatively socially downward mobile. The girls who were highly masculine did not show that. They seemed to be somehow resilient. And their social mobility was unaffected really by their gender expression, whereas for boys, the highly masculine ones were more hung together. They were in more physical jobs and ones with lower pay. Okay. So some of the key findings and messages, and I don't think this will be any surprise, but I think what we're illustrating here is that we can take global survey data that was not designed for any of this research, and we can interrogate it in ways that enable us to draw conclusions and develop hypotheses that relate to ways in which norms influence health and development. And that's what the first bullet here, the first point really expresses is that we found in many different places in the world for many different health outcomes at different life stages that normative influences on health exist, often in very powerful ways, often in our own backyard, and that we need to be paying attention to these. We found through our research, and again, unlike what has been shown through other studies, other means of interrogation, that norms are internalized early. Our case studies went down, to school-age children. They're often manifest in unexpected ways. We often found as we went through these investigations that we got results that at first seemed counterintuitive, and it took a while to wrap our minds around it to understand the ways in which norms might be playing out, and that we had not thought about that until we began to explore that quantitatively. That there are multiple health consequences. They may operate differently for boys and girls. And there are intersections with other factors that are very important to consider. And that ultimately the context really matters, that we can develop hypotheses, but I think as our Zambia HIV case illustrates, we really need to go down to the local level to then begin to understand why might this be, does this make sense? And begin to pair our quantitative and qualitative analyses more intentionally. Next slide. We found that norms for acceptable appearance and behavior are very powerful and impact people throughout the life course, that these vary over space and time. They intersect with other social factors, that these things really affect everyone. Much of the conversation around gender equality and development has been around women and girls. And one of the things that this body of work and others on gender norms really points out is that these influences are acting upon all of us, and that it's actually influencing all of our health, our development, our opportunities. Adolescents are especially susceptible, though, we would say, and there are important influences through family, as you saw, through peers, through other community members, as you could see in the Zambia case study. That the threat of sanctions, or that idea of a reference group, appears to be very real in this quantitative data, and that the choice of your gender proxy in survey data really requires some careful thought. Sometimes attitudinal data may be effective. Sometimes behavioral data may be useful. In the Zambia case, it really was the difference between them that turned out to be really quite revealing. And so, we hope that this opens up and brings more people into this field and into these exciting ways of looking at survey data and trying to understand ways in which norms impact our health and our development. Ben, anything more to add there?
Absolutely not. Perfect. You were perfect.
So let's see if we can get at the very least a few questions answered. Dagna Shu.
May I just say very quickly, just yes. Acknowledging that this is a body of work that had many contributors from all over the world. Here you can see them listed on the quantitative analyses. These are the various partnerships that we had and the individuals that were involved, and Ben and I are simply representing the work of this large body of people to you. So thank you.
Excellent. So thank you for this great talk. So we have a couple of questions now. Dagna Shu, please.
Yes, thank you very much. Can you hear me?
Yeah.
Yes.
Thank you very much. This is very, very insightful. I'm a doctoral candidate working on violence against persons with disabilities in Africa at the University of Pretoria Faculty of Law. And in your presentations, one theme that seems to have not been seen clearly is that of disability. How, of course, you mentioned in terms of identifying the age category of your respondents or research participants. There is this DALI item as a factor, the disability adjusted life years. But all in all, how to what extent has disability and the various types of disabilities, intellectual disabilities, sensory impairments, etc., been incorporated in your analysis as a factor? If yes, what was the impact of that? If not, why didn't you incorporate disability issues as an important determinantal factor? Thank you.
Yeah, maybe I'll start, and Ben, you can add. Yeah, thank you very much for the question. It's a very good one, and I guess I would answer that by saying that the case studies that we presented here and that are more broadly reflected in the Lancet series and some of our subsequent work is really only illustrative. We feel like we are just scratching the surface, and that's part of what I think is so exciting about this field. And we did not find a great example, where we could put together a construct around that particular issue yet. But not to say that we by any means exhausted that. I think we would highly encourage you to to think about applying that, I think is extremely important. I have no doubt that you would find these relationships within quantitative survey data, and it would be exciting to see that. But just to say that this work is just beginning and it's highly incomplete. And so thank you for pointing this out.
Yeah, and if I don't have anything to add, if maybe the only thing is that you have seen in this presentation a part of the results of, what was it, Gary, 4 years of work?
Mm-hmm. Yeah.
So you have no ideas how many cul-de-sac we had to smash against before we managed to get to what is really, we are very aware these are proxies of gender norms, right? Is only in 1 or 2 cases, as in the Brazil case, we really had data on what adolescents thought, their parents thought of them, of their physical appearance, which was the closest we got to a semi-decent measure of gender norms. So because of that kind of risk, and because of the fact that we couldn't collect new data, they obviously, for this initiative, they kind of restricted the possibility. And then when we started conducting analysis, often we went down to sample sizes that didn't allow us to come up with statistically significant conclusions. So that's also a factor why we did discuss actually integrating disability. But data availability was a huge issue. But I do believe it's extremely important, and thank you for raising that point.
Yeah, maybe just to add one thing quickly is that what's missing often was a reflection of bias in our view. And as I mentioned, so much of the data is around sexual reproductive health, HIV, and violence against women, and it comes from a particular perspective. The fact that norms affect all aspects of our life, and in some way or another, all of us, and the fact that the data are so missing about things like disability, I think reflects the bias that's there. And I think it's really important to point that out.
Okay, so we have now another question from Christina. You're mute.
So I wanted to thank you for the talk, and the examples are great. So very exciting. And I'm very curious about the taboo gap, okay, which seems relatively important. And by this, if I understand well, I mean the discordance between the attitude and the behavior, the should and the do. And, you seem to assume that is an important hypothesis that this taboo gap has a huge influence on health outcomes. Now, the question is the taboo gap, what's behind the taboo gap? So on the one hand, we may say, we know, in fact, that women tend to express in surveys greater adherence to the should, okay? And then maybe they don't. And so the taboo gap seems huge, for example, for women, but in reality, it is not. It is not that real. On the other hand, and somebody who asked a question before pointed to that, what is usually done, the practice may have a very different meaning for women and men. So women may be forced to have sex, and so the discordance may be a forced one, okay, in the sense that the practice is forced on me, while the should is not. And so I would like to understand better how this discordance, being of one nature or another, it depends, would influence the health outcome. For example, if you think that, there is a real discordance, that women, really believe in the should, but then the practice, maybe they are forced or whatever, then they will use less health services because you will reveal that I behave badly, for example. So I would like to understand, okay, how you understand this very interesting, taboo gap and the causal influence, because it depends how you understand it, how you understand the causal influence on the health outcome.
Yeah, thank you. Maybe I'll offer a few thoughts, and thank you for that very insightful question. And I would say we're really still trying to unpack that, and I think further investigation at the local level is required. But part of what I would say have gleaned from our review of the literature is that boys and girls in Zambia are kind of educated around the idea that boys dominate and girls accept, and that the absent voice idea from Panama really resonated with me. And in our examination of the literature, I would say that's often what we saw is that girls hear it from home, school, church, that you don't have sex, but as a girl, you certainly don't initiate sex. And actually, culturally, the boys, as they become adolescents, are moved from that place of you don't have sex to one of, to be a man, you need to dominate. And you actually should have perhaps multiple sexual partners, but your sexual prowess is closely linked to your manhood. And so in some ways, the boys become almost more dissonant from what they were initially taught. Whereas for girls, the message remains fairly consistent that this is not something that you do. It's not something that you actually in the end can even control. And in both cases, it sets up a dynamic where neither the boy nor the girl want to seek help within the health system. And often when they do go and seek help, they're often shamed for what they're doing, and they end up not even getting the services. But then another important aspect that seems to enter in that you alluded to, and that the previous question had alluded to around coercion, is also the idea that for many girls, as they reach adolescence and in situations of poverty, transactional sex becomes an option that has some appeal to it, financially and in a variety of ways. And sometimes culturally, it's a way of getting things that give you some status and in your community with your peers, and those kinds of factors begin to enter in as well. So that there's kind of a spectrum from coercion to being in a social situation that your options are more limited, and the balance begins to shift between do I really not do this, or maybe I do it and just don't tell anyone, and it provides some things for me. Or maybe people even know that I'm doing it, and they may actually implicitly encourage it because it's bringing some value to the family. So the dynamics really become quite complex. But in that construct, there are some biological reasons that girls become at higher risk than the boys. And we have data to suggest that more often than boys, girls are in relationships with older men. There's more of a power dynamic differential between them. The girl is relatively less powerful in those relationships. And the man has a higher chance of being HIV positive and having multiple sexual partners. And then that younger girl that he has sex with is getting exposed to HIV at rates beyond the adolescent boys of the same age as her in that community. That's part of how we're kind of putting it together again, in a construct that really is a hypothesis that then really needs to be borne out through qualitative research.
And if I can just add to that, I am mixed methods, but much of my research is qualitative. And to me, those data speak to something that Amanda herself has found in her work, but that we found in India, in Cameroon, in Senegal, in Uganda. In the ways in which the courting, I think there are two major important things to say here. Number one is that, of course, control of women's reproductive capacities is one way of gatekeeping family honor. So if your daughter remains pregnant and you don't know, and she's not married, that's a great shame for the family, right? Which is why if a girl is having sex with a boy, she's definitely not going to want for people to know, because the pregnancy is seen in the girl, is not seen in the boy, obviously, right? So the boy can hide away in the bushes, if you like, and deny the fact. The girl can't deny the fact. So that's the first thing that is quite important to me. The second thing that is important, and that is that there has been with the increase in literacy and increasing availability of technology, adolescents have experienced. There's a great work done in Rwanda how grandparents. There was this intergenerational communication, these interviews on this particular topic, and so grandparents used to date with their parents supervising this. Now their children went to school. Now they're able to read and write, so they send each other love letters, and so this shakes things up. Now the children of these children have access to Facebook and WhatsApp, and they start chatting on WhatsApp without their parents knowing, which facilitates eloping. And then the complexity of how this dynamic is used, is exploited for power reasons, is incredible, including in South America, girls who actually use escaping from family control, having sex with boys to escape very often violent families, because then they come back home and say, well, I had sex with this guy, so what do we do now? And the parents say, oh, now you need to marry the guy. And the girl says, well, I'm very happy to marry the guy because I want out from this family. So really the complexity of how that, clearly the quantitative data don't allow to engage with that complexity and open up the point, social desirability bias, which is very, very profound and true to the coercion issue. But then when we start comparing and contrasting this qualitative data and emergence, that kind to me increases the validity, if not of every single participant in there, of the story that emerges as part of a larger piece that requires exploring further research avenues.
Definitely. So this is a fascinating discussion, but I believe we have to leave it here. We are way over time. I'm really sorry for those of you who contacted me with private messages or who posted questions in the chat. I mean, Paulius will be sharing the chat with the co-authors, and of course, I encourage all of you interested in contacting the authors to just send them an email. So thank you very much, Gary and Ben, for this really fascinating talk. And to the rest of you, thank you for being here, and stay tuned. I don't know if we have another session in 2 weeks, Paulius?
We are confirming the talk in 3 weeks, okay. And we definitely have a lot more until December. So we will be in touch via email. And thank you so much for joining, to the speakers and all of you.
Thank you.
Thank you.
Thank you.